Okay, let's unpack this.
Let's do it.
We are embarking on a deep dive into what is arguably the most fundamental and certainly, I think, the most exciting shift happening in medical science today. The move from treating population averages to truly treating the individual patient.
Precisely. We are talking about precision medicine, and, we're using one of the cornerstones of clinical knowledge, Harrison's Principles of Internal Medicine, as our authoritative guide here.
Right.
The discussion in the latest edition is just crucial because it charts this transition. How do we pivot away from diagnostics based on, generalized population studies, averages, broad guidelines?
The stuff we've relied on for decades.
Exactly. And move toward a patient-specific precision approach. And look, this isn't just some abstract academic idea.
No.
It is fundamentally defining the future of 21st century clinical care. It's happening now.
Our mission today, then, is to really dissect the foundational concepts that necessitate this pivot. We're following Harrison's argument here.
Yeah.
From the recognized limitations of current evidence-based medicine through the centuries-long history of how we even classify diseases, and finally, getting into the modern understanding of genomic context and, frankly, highly complex clinical presentations.
It's quite a journey, actually, and it explains why the old ways, they were effective for maybe 3 decades, right? But they've essentially hit a ceiling.
A plateau.
A plateau, exactly. And it justifies why we need this new, rigorous, and highly individualized framework to, push past that ceiling.
So let's start right there with that recognized ceiling. Evidence-based medicine, EBM.
Okay.
For 30 years, EBM has been, the gold standard, the moral compass demanding we base clinical decisions on the best available research.
Yeah.
But Harrison's, it acknowledges its substantial limitations right up front, doesn't it?
It does, absolutely right. The text is very clear. It calls EBM an ideal rather than a finished set of tools, which is a really telling phrase.
It is.
It provided this unparalleled, rigorous framework for evaluating treatments, standardizing care across systems, vital for quality control, no doubt.
Sure.
But when you actually delve into the guidelines generated by EBM, the data is, it's quite sobering, especially regarding the quality of the evidence base itself.
Okay, so what's the most critical piece of data then? The bit that highlights this inherent failure or, the gap in the evidence?
Well, it really boils down to the sheer volume of comprehensive, high-quality clinical trials we actually have.
Right.
Harrison's points to an extensive examination of major cardiovascular guidelines. And this is a field, remember, that conducts some of the most rigorous, well-funded clinical trials globally.
Top-tier stuff.
Absolutely. And it revealed that less than 15%, 15% of the total recommendations were actually based on the highest level of clinical trial evidence. The randomized controlled trials, the RCTs.
Less than 15%. So, okay, flip that around. For over 85% of clinical decisions, even in a high trial field like cardiology, physicians are relying on something less than that gold standard data EBM supposedly demands.
Exactly. And maybe the most frustrating part, according to the sources Harrison cites, is that this proportion, this less than 15%, it didn't improve over a decade of intense research.
Wow.
So the majority of clinical practice is still based on, consensus, expert opinion, lower levels of evidence, simply because comprehensive RCTs for every clinical permutation, every patient type, every comorbidity, every unique circumstance, they're just impossible to conduct, practically, economically.
Just can't be done for everything.
Can't be done. So even when we do have that high-level evidence, we run smack into the core philosophical limitation that precision medicine really seeks to overcome.
And that's the problem of the mythical average patient.
That's the absolute crux of it. Clinical trial outcomes, by design, give you the expected response for the average patient enrolled in that specific cohort.
But that average patient?
Statistically speaking, they don't exist. Not in your consulting room, anyway.
And this is where that tension really arises, isn't it? EBM demands we use this aggregated population data, which, mathematically it's sound.
Sure.
But clinical practice demands we treat the specific individual sitting right in front of us. Their biology, their environment, their specific disease path might be completely unique. They might fall way outside the bell curve of that trial population.
And if meta-analyses, which are meant to combine trials to get more power, if they fail when adequate RCTs just don't exist...
Which we just established is most of the time.
Right. And if most of the subtle, complex, or rare conditions we face in the clinic are never going to be thoroughly tested in an RCT, Well, we're left constantly trying to bridge this massive chasm between population science and personal reality.
Hmm.
And that gap, that failure of population-level data to perfectly predict individual outcomes, that's precisely why the concept of precision medicine has become absolutely essential. It's moved from being, an interesting theory to the essential driving force in modern medical development.
It's a formal recognition then.
It is. It's the formal recognition that, okay, patient preferences matter, the clinician's experience matters, excellent clinical reasoning skills are crucial, but they must be supplemented now by this molecular and genomic fidelity.
Okay. Now that we've established why EBM needs this refinement, this new layer, let's dive into how we classify disease in the first place. Because Harrison argues our very method of naming illnesses is, well, kind of flawed, rooted in centuries-old practices that just lacked the tools we have now.
Yeah. This is where we trace what the text calls the arc of reductionism. Historically, disease classification, or nosology, it was always constrained by the diagnostic tech available at the time.
Makes sense.
Ancient physicians, think Galen, right? They had holistic, descriptive views of illness. Limited by their understanding of anatomy back then, the modern framework, the one we largely still operate under, was institutionalized way back in the 18th century.
And we're talking about the era of Giovanni Battista Morgagni here. His work profoundly changed medical diagnosis.
Absolutely. 1761, Morgagni publishes De Sedibus et Causis Morborum per Anatomum Indagatis, rough translation. The seats and causes of diseases investigated by anatomy.
Catchy title.
Maybe not, but it was a monumental achievement. For the first time, he systematically correlated the clinical features observed in living patients with the specific pathoanatomy found in, get this, over 600 autopsies.
600, wow. So he essentially took illness, which before was maybe a theory of humors or imbalances.
Right, vague stuff.
And tied it to something physical you could actually point to. A lesion in an organ.
It was completely revolutionary. Provided an anatomic basis for disease. It facilitated the conquest of many conditions, dramatically improved diagnostics through the 19th and 20th centuries, but there was unintended consequence.
Okay. What was that?
Diseases tended to be characterized primarily by the end organ where the main syndrome showed up.
Like kidney disease or heart disease.
Exactly. And often by the late-stage presentation. Why? Because that's when the patient died and was available for autopsy.
Right. This sounds like what Harrison calls the Eslerian oversimplification, where diagnoses became overly inclusive, grouping things together.
Correct. The system was built on inductive generalization, applying Occam's razor, reducing disease complexity to its simplest, most observable form. And this led to a really significant shortcoming.
Huge was.
A fundamental failure to distinguish the underlying etiology, the actual cause, of different diseases that happen to share a common late-stage endpoint.
Can you give us a clear illustration of that? Grouping distinct causes under one common label.
Sure. Think about end-stage kidney disease or end-stage heart failure. These are pathophenotypes, the observable ultimate end results of organ damage.
Okay.
But dozens, literally dozens of completely distinct underlying causes. Specific genetic mutations, maybe viral infections, varied environmental exposures, chronic inflammatory processes. They can all lead to the exact same failure of that organ.
So if your diagnosis just stops at heart failure,
then your prognostic information is broad, it's vague, and your therapeutic choice. It might just be a shot in the dark, because you lack the understanding of the subtle molecular complexities driving that specific patient's condition.
And this lack of knowing the specific cause is precisely why refining classification became so necessary. Like what's been done with lymphomas, right? They're not just lymphoma anymore.
Exactly. Highly stratified by molecular markers now. That distinction is key. For predictable prognosis, yes, but more importantly, for effective, targeted therapy. This inadequacy in the older system, it really spurred the mid-20th century push towards molecular medicine.
Right, that was the era of big hope, wasn't it? The conventional reductionist paradigm. Let's find the single specific molecular cause for every disease.
That was the idealized possibility. And look, it worked spectacularly for conditions driven by a simple single factor, absolutely transformative in some areas. But then, clinical reality complicated things significantly.
How so?
The medical profession discovered that pure reductionism, well, it had fundamental limits.
And the classic example Harrison uses to illustrate this kind of breaking point is sickle cell disease.
It's the perfect illustration, really. Molecular knowledge hitting a wall of biological complicity. We know the exact mutation, beta globin chain, nailed it down.
Decades ago.
Yeah, but that knowledge alone does not predict how the disease will manifest in an individual. Why does one person develop a catastrophic stroke? Another suffers repeated, agonizing, painful crises in their joints, and a third gets severe acute chest syndrome.
Same mutation, wildly different outcomes.
Exactly. The molecular cause is identical, yet the clinical outcomes are incredibly divergent.
So knowing the primary driver, the mutation, was necessary, but clearly not sufficient to predict the clinical outcome. And that revealed this extraordinary biologic variety and complexity we hadn't really accounted for in that simple reductionist model.
And this brings us squarely to the Human Genome Project. Remember the hype? Oh, yeah.
Yeah.
Monumental promise. Immediate revelation. We expected to find the monogenic, oligogenic, polygenic cause for virtually every disease, especially the common ones, hypertension, diabetes.
The ultimate reductionist answer, delivered by technology, that was the dream.
Yeah.
But as the pool of sequenced genomes grew and grew, the results, particularly for those common complex diseases, well, they led to what the text nicely describes as a certain humbling plateau.
Humbling is a good word for it.
It is. Aside from identifying lots of rare variants, the expected immediate revelations for common diseases just didn't fully materialize in the way people had hoped.
That must have been a profoundly, humbling moment for scientists who'd maybe promised sweeping cures were just around the corner. What did that realization that pure genetics alone wasn't the whole answer? What did that change fundamentally about how researchers approached biology?
It forced a realization, a really crucial one, that disease isn't just the static genetic blueprint. That view missed the critical integrating factor.
Like what? The paramount roles of epigenetics, how genes are turned on or off, which, in turn, are significantly modulated by environmental exposures, the composition of your gut microbiome, the unique history of individual experiences over an entire lifetime.
So it's not just the code, it's how the code is read and used over time.
Precisely. The disease is the execution of that blueprint over time, within a unique biological and social context.
There's a visual Harrison's uses, what we can maybe call the arc of reductionism, that summarizes this whole trajectory of medical thinking beautifully. It shows how medicine moved inward, deeper and deeper, and is now kind of being forced to move outward again to reintegrate.
Yeah, that image maps out the historical progression perfectly. Let's walk through it. So, 18th century. Medical knowledge is based on a holistic view. You describe a sick person who has physis, that general term for consumption or wasting disease. Focus on the whole person.
Then Morgagni comes along.
Right. His influence pushes us toward physical specificity. By the early 19th century, we refined the diagnosis to lesions of organs and tissues. We could identify, say, caseating granulomata in the lung. We moved from the person to the damaged organ.
Yep.
Late 19th century, massive leap with germ theory. We moved to lesions of cells and microbes. We identify Mycobacterium tuberculosis as the single causative agent of TB.
That was reductionism at its absolute most triumphant, right?
Yeah.
Reducing a complex syndrome down to a single microbe.
It was a huge win. And the late 20th century saw us push even further. Identifying lesions at the molecular level, maybe using interferon testing, identifying specific protein markers associated with the disease process.
Getting smaller and smaller.
Smaller and smaller. That entire journey over 2 centuries was this steady, incredibly successful move inward, reducing complexity, and now the diagram shows us in the 21st century facing the challenge of reassembly.
Reassembly, I like that.
We've hit the limits of pure reductionism. We know many of the molecular components, but we lack the full systems-level understanding of how they all interact dynamically. This revealed the need to return to holism, but not the old holism, an integrative holism.
Oh, okay. Different.
One that places genomic and environmental context as absolutely central to all dimensions of the disease process.
So the stage is now set for precision medicine, where the disease definition itself has to become more precise, progressively individualized, and capable of integrating this massive, multidimensional complexity we've just uncovered.
Exactly. And let's discuss the profound consequence of that observational history we just mapped out. Oversimplification.
Right.
Categorizing similar-looking individuals into broad groups. Well, that's what observational science naturally does. It simplifies diagnosis, it facilitates applying specific therapies broadly, which is efficient, right, for managing large populations, generating simple guidelines.
But as we said right at the start, this population efficiency comes at a massive cost in clinical effectiveness for the individual patient sitting in front of you.
A massive cost. Harrison's highlights this really starkly. It leads to significant predictive inaccuracies and substantial segments of the patient population that simply do not respond to the consensus most effective drugs.
And we mentioned a number earlier.
As we noted, by some conservative estimates, this non-response rate can be as high as 60%, 60, for many common drug classes.
60%. Just pause on that. When a clinician prescribes the consensus best practice drug, they know statistically that maybe 6 out of 10 times that drug either won't work or won't work optimally for this individual patient, simply because the diagnostic label is too broad.
Think about the waste.
It's a colossal waste of resources, money, healthcare effort, and more importantly, time. Precious time when a patient is suffering and not getting better.
It's really an ethical and economic crisis built right into our current structure.
Yeah.
It absolutely necessitates a much more nuanced approach. And that begins by aggressively refining the phenotype, the observable characteristics of the disease.
Okay, so let's define that. We call those readily observable differences the phenotypes.
Yes. And astute clinicians, let's be clear, have always recognized these subtle, visible, vivid differences in how the same nominal disease presents.
Good point.
Sometimes these differences, often driven by new technology becoming available, lead to formal subclassifications. Again, heart failure is the perfect illustration here. We move beyond just heart failure to classifying it based on reduced ejection fraction, HFrEF, versus preserved ejection fraction, HFpEF.
And that simple distinction, which was enabled by echocardiography,
Yeah,
a piece of tech,
exactly.
it dramatically changes the entire treatment approach. That's phenotypic refinement in action right there.
Absolutely. And then there's the endophenotype. Now, this term is crucial for precision medicine, maybe less common in general discussion.
Okay, let's spend a moment making sure we fully grasp the distinction. Visible phenotype versus internal endophenotype.
Certainly. So the phenotype is what you observe clinically. The patient's high blood pressure, their shortness of breath, the visible skin rash, things you can see or measure directly on the patient.
Got it.
The endophenotype, by contrast, refers to internal measurable biomarkers that refine the diagnosis but are not clinically apparent. You cannot see them just by looking at or examining the patient.
So we're talking lab measures, internal characteristics, imaging findings maybe?
Precisely. They are the non-apparent links between a disease driver, like a gene mutation, and the final clinical presentation. For example, think about various inflammatory vasculitis diseases where blood vessels get inflamed.
Okay.
The phenotype might simply be inflamed blood vessels, causing certain symptoms, but the endophenotype involves distinctions among them based on sophisticated serologies, specific autoantibodies in the blood perhaps, or immunophenotyping markers on T cells, things you need a lab for.
And these internal markers let us subclassify the disease.
Because these specific subclasses might improve prognosis or, more importantly, allow for the application of effective, precise therapies. They differentiate conditions that might look very similar externally.
Okay, so precision medicine now is formally coupling that deep molecular reductionism from the past century, finding the ultimate disease drivers with an integrative, systems-level understanding of the detailed pathophenotype, both the visible stuff and the non-visible internal stuff.
And the absolute key insight, the glue that ties all this complexity together, is the genomic context, specifically the role of modifier genes.
This sounds like the answer to that divergence puzzle we talked about with skill cell, isn't it?
It is the ultimate determinant, really. Every single person's genomic context is distinctive, unique. This context, which is made up of thousands of modifier genes and their incredibly complex interactions, that dictates how a primary disease driver will actually manifest clinically. This resolves our sickle cell paradox. The primary mutation in beta-globin is the same in everyone who has the disease. But the modifier genes, genes regulating blood vessel health, inflammatory response, coagulation pathways, you name it, they're different for everyone. And they determine whether that specific person gets a stroke or acute chest syndrome or mainly painful crises.
Okay, that makes sense. But now we have to face the clinical reality. Harrison's highlights two major compounding principles that every clinician has to be acutely aware of when they're trying to formulate a precision strategy, because they really embody this immense complexity of biological variety. Let's dive into the first one, convergent phenotypes.
Right. What's fascinating here is it seems like the molecular world has a somewhat limited set of ways to fail, or maybe a limited set of ways to show failure at the organ level.
Okay.
That's the definition of convergent phenotypes. Patients with radically different underlying diseases manifesting similar, sometimes even identical, pathophenotypes. The end result looks the same, even though the starting problem is completely different.
The text provides some incredible visuals illustrating this. It's like a diagnostic decoy. Let's focus on the example of the hypertrophic myocardium, the thickened heart muscle.
Okay, so imagine the pathophenotype is a hypertrophied, severely thickened heart muscle, maybe detected on an echo or MRI. The list of underlying causes that can all converge on this single appearance is just staggering.
Lay it on us.
It includes mutations in over 11 different sarcomeric proteins, the proteins of the heart muscle itself, often with over 1,400 distinct variants identified across just those genes.
Wow.
Then you have infiltrative diseases like Fabry's disease or Pompey's disease, where abnormal material actually deposits in the heart muscle, making it thick.
Different mechanism entirely.
Totally different. Then critical aortic stenosis, a structural problem with a valve, making the heart work harder, or simply untreated, long-standing hypertension, high blood pressure, making the heart muscle bulk up over time.
Okay, so 11 different proteins with over 1,000 variants, plus structural issues, plus metabolic storage disorders, plus straightforward high blood pressure,
Yeah.
all resulting in a heart that looks visually thickened in the same way.
Pretty much. And if you treat that patient for severe hypertension, but the real problem is their genetic Fabry's disease, well, you won't solve their underlying issue, will you?
Not at all.
The primary clinical challenge is you must drill down. You have to know which one of those dozens of distinct processes is the actual underlying molecular driver, even though the end result, that thickened heart, looks identical across them.
Let's take the second example of convergence from Harrison's, thrombotic microangiopathy, or TMA. This is where the diagnostic complexity gets truly, well, frankly, frightening.
It really does. TMA is a microscopic finding. You see clots forming in tiny blood vessels, which leads to organ damage, often hitting the kidneys hard. Now, this specific pathology, this TMA finding under the microscope, it's shared among conditions like malignant hypertension, dangerously high blood pressure, scleroderma renal crisis, a complication of a connective tissue disorder, thrombocytopenic purpura, TTP, a hematological emergency, eclampsia, a severe complication of pregnancy, and antiphospholipid syndrome, APS, an autoimmune condition.
Wait, let me get that straight. An autoimmune disorder, a kidney issue from a connective tissue disease, a blood pressure emergency, a pregnancy complication, and a blood clotting disorder. They all can yield the same dangerous pathology under the microscope.
That is a phenomenal range, isn't it? It is a truly complex clinical minefield, and this convergence is rampant. It applies also to cancer. As we apply genetic analysis to tumors that originate from the same organ, say breast cancer, we detect substantial molecular heterogeneity, meaning the same breast cancer found in two different women may actually be driven by different mutations and require two completely different targeted therapies. Same organ, same general look, different drivers, convergence.
Okay, so on the flip side of that coin, we face the equally perplexing situation of divergent phenotypes.
Right. Here, the molecular cause is known, it's identical, but the disease manifests in radically different ways in different people. In genetics, we sometimes call this phenomenon incomplete penetrance.
So we're back to our sickle cell puzzle again. Or cystic fibrosis is another great example, right? The CFTR gene mutation is known.
Known perfectly.
But the presentation ranges from devastating lung destruction in one patient to mainly pancreatic insufficiency in another, or even just male infertility in some. Highly varied.
And a superb non-genetic example Harrison's gives is the antiphospholipid syndrome, APS, which we just mentioned under convergence too.
Oh, interesting. How does it show divergence?
Well, the same basic autoimmune condition, having these antiphospholipid antibodies, it can look like a neurological problem, maybe syncope, fainting, or a thrombotic stroke. It could look like a cardiac problem, heart failure or angina. It could be a deep vein thrombosis in the leg, or maybe just a specific skin finding called levato reticularis.
So it can hit almost any organ system.
It can span virtually every organ system despite the shared core disease mechanism, the antibodies. That's divergence.
Okay, wait a second. If convergence, different diseases looking the same, and divergence, the same disease looking different, are the norm, and the genomic context is unique to every single person, aren't we just admitting that medicine is impossibly complex? How can any health system, any doctor, actually manage that staggering data load? It sounds overwhelming.
That is the absolutely essential critical question. And Harrison's addresses it directly when it talks about achieving actionable precision. Given this staggering complexity, the DNA, the RNA, the proteins, the metabolites, the whole microbiome, the epigenetics, the social history, how precise do we actually need to be?
Right. Is perfect knowledge the goal? or even possible.
Complete knowledge of a person's comprehensive ohm, their entire biological data set, is currently impossible to acquire, let alone interpret fully.
So what's the guiding principle then? What brings this complexity back down to something manageable, something clinically useful?
The solution, according to Harrison's, lies in two key concepts: actionability and redundancy. Precision is only necessary, only clinically justified, when it is actionable. Meaning, when it dictates a definite change in prognosis, or surveillance strategy, or, most importantly, treatment. Excessive, non-actionable testing, finding variations of unknown significance. For example, it simply causes unnecessary patient anxiety, huge financial cost, and even clinical risk from follow-up procedures.
Okay, be actionable. But how do we achieve effective prediction, effective action, without having all the information? That seems like the paradox.
This is where the concept of overdetermined biological networks comes into play. It's a fascinating idea.
Overdetermined.
Yeah. Think of the complex molecular networks that govern phenotype, how a disease looks and behaves. Think of them like a city's critical infrastructure, say its power grid or its transportation network.
Okay.
These systems are usually highly redundant, right? There isn't just one single power line into a neighborhood or one single road to the hospital. If one major pathway, let's call it one primary disease driver, is blocked or faulty, the system often has automatic backup roads, alternative pathways that can achieve the same or a similar final functional goal.
So redundancy means the system is robust. It can work around problems.
Exactly. It's built to be resilient. And because of this, we don't necessarily need to map every single secondary backup route to fix the problem, or at least mitigate it. This biological redundancy means a clinician doesn't need every minute molecular detail about every possible pathway.
So what do they need?
They need to identify and target the primary, most heavily weighted drivers, the main roads, if you like, which are then modified in a somewhat predictable way by other genomic features, the side streets. We just need to identify the key choke points in the network that we can actually disrupt therapeutically to achieve a meaningful clinical response.
So the goal isn't complete knowledge, it's finding the minimum actionable data set.
That's the ultimate practical goal. Find the essential information needed to make a difference.
Okay. That structural framework, pursuing actionable, high-yield targets within a redundant system that allows us to move into real-world validation, doesn't it? Harrison's makes a really critical point about bridging the pre-genomic era with the post-genomic one. It proves that personalized medicine isn't entirely new. It's just now being infused with this incredible molecular fidelity.
That's exactly right. Clinicians, good clinicians, were practicing sophisticated personalized medicine long before the genome was sequenced. They did it through detailed history taking, careful observation, individualized choice, and titration of therapy.
Wow.
By responding meticulously to the phenotype they observed in the patient in front of them.
And heart failure management remains the prime example of this pre-genomic precision, as we touched on earlier.
Absolutely. In the pre-genomic era, treatment was highly individualized. You titrated drugs, diuretics, beta blockers, ACE inhibitors based entirely on observed pathophysiologic phenotypes. Is the patient congested? What are their symptoms? How is their heart contracting on exam or simple tests?
Right, adjusting based on response.
Exactly. This observational precision, driven by clinical insight and maybe early tech tools like the first echoes, led directly to that crucial subclassification of heart failure into HFREF, reduced ejection fraction, versus HFpEF, preserved ejection fraction.
And that subclassification turned out to be absolutely vital because HFrEF responds pretty well to many existing drug classes, while HFpEF often does not. It demands completely different therapeutic strategies. That was a precision move driven by observation and technology well before we could sequence a patient's whole genome routinely.
Precisely. Now, fast forward to the post-genomic era, we see that same drive for precision validated and dramatically accelerated by molecular understanding. A great example Harrison's uses for this molecular validation is pulmonary arterial hypertension, PAH. Before the 1990s, PAH was often a rapidly lethal condition, very few effective treatments. But as molecular characterization of the pulmonary blood vessels advanced, we identified specific vascular abnormalities, the actual mechanism of the disease. And that led to the development of molecularly based agents like prostacyclin congeners, endothelin receptor antagonists.
And those molecular insights saved lives because they targeted the mechanism driving the vascular abnormality, not just the symptom of high pressure in the lungs.
Exactly. And the refinement continues today. Genomic characterization is now revealing distinct genotypes within PAH that yield unique molecular endophenotypes.
Like what?
For instance, researchers have identified some patients who exhibit a primarily fibrotic endophenotype. Their vessels get stiff and scarred. And this seems to be governed by specific molecules, like the scaffold protein NEDD9 and enhanced collagen III expression.
So knowing that,
It confirms the need for even more individualized therapeutic targeting. A potential new drug could specifically target that perivascular fibrosis pathway rather than just generally dilating blood vessels. It moves treatment away from generalized effects towards true mechanism repair based on the patient's specific molecular profile.
we see similar, really critical shifts in diagnostics happening across specialties too, right? Particularly in neurology, maybe, where diseases once lumped together are being, well, sometimes brutally separated based on new molecular markers.
Oh, absolutely. Dementias are a prime example. Once considered broad, maybe single-cause disorders, but with varied clinical expressions, they're now increasingly categorized based on specific genes involved, specific molecular pathways that are disrupted, even the specific site in the brain where aggregated proteins first form and then spread.
So you can move from a general label like frontotemporal dementia to linking the exact clinical presentation, whether it's mainly behavioral disturbances or a progressive language problem like aphasia, to specific underlying genotypes or protein pathologies like tau or TDP43. And the reclassification of neuromyelitis optica, NMO, is just a stunning example of actionable precision, fundamentally altering patient outcomes.
It truly is. NMO was historically confused with multiple sclerosis, MS script. The symptoms, like vision loss and spinal cord inflammation, overlapped significantly.
Right.
But the pivotal discovery of specific autoantibodies, first against a water channel protein called aquaporin-4, AQP4, and later against myelin oligodendrocyte glycoprotein, MOG, in some other patients allowed NMO and related disorders to be definitively classified as completely separate entities from MS.
And why is that distinction so vital?
Because NMO often requires different, sometimes more aggressive immunosuppressant treatments than typical MS. In fact, some MS treatments can actually make NMO worse.
Wow.
So treating NMO like MS based on the old, purely clinical phenotype could lead to significantly worse outcomes. It shows the incredibly high clinical stakes of getting that precise endophenotype right.
Right.
It's not academic, it's life-changing.
The ultimate poster child, though, for precision medicine, particularly targeted therapy, remains cancer, doesn't it? Although, as Harrison points out, it also reveals the unique challenges.
Yes, absolutely. In the pre-genomic era of cancer, chemotherapy was chosen broadly based on the tissue-affected lung, breast, colon, and maybe the histology, how the cells looked under the microscope. Treatment success was highly variable, often quite brutal with side effects.
We remember those days.
But as cancer genome sequencing exploded onto the scene, we made a crucial discovery. It turns out there's a limited number of core oncogenic pathways, maybe less than 20, that seem to drive the great majority of malignancies, regardless of the specific organ where the cancer first manifests.
That provided the template, the rationale for precisely targeted therapies,
Yeah.
which have delivered dramatic changes in response in some cancers. Things like imitinib for chronic myeloid leukemia, CML,
Change the face of CML.
or drugs like erlotinib or osimertinib for specific EGFR mutations in non-small cell lung cancers. Game changers.
Absolutely game changers for those specific patient subsets. However, cancer also starkly reveals the unique challenge of precision therapeutics, the dynamic nature of the disease itself.
Meaning the cancer fights back.
It adapts. The mutational landscape within a tumor is constantly evolving, partly just randomly, but also under the selective pressure from the targeted drug. This inevitably leads to the selection and growth of resistant clones that no longer respond to that initial therapy.
So the precision target disappears or changes.
Exactly. Furthermore, very few cancers, unfortunately, can be cured by any single targeted agent, no matter how precise it is initially. This necessitates rational polypharmaceutical approaches using combinations of drugs.
How do we choose the combinations?
Ideally, by targeting alternative, redundant pathways the cancer might use to achieve the same oncogenic goals, like uncontrolled growth or survival. This concept ties directly back to those overdetermined biological networks we discussed. You block the main road, the cancer tries a side street, so you need to block that too. So even with the most precise initial diagnosis, the tumor heterogeneity and this dynamic evolution present continuous moving targets. It demands longitudinal monitoring, maybe repeated biopsies or liquid biopsies, multi-omic analyses over time to track the changes.
It's a constant chess game. And the strategy identifying the causative network and its vulnerabilities, anticipating resistance, it actually mirrors the strategies we've used for decades in infectious diseases.
How so?
Well, identifying the causative organism, the bacteria or virus, and determining its sensitivity to various antibiotics or antivirals, that allows for a precise treatment strategy. And we often use combinatorial therapies there too, precisely to combat the development of resistance.
Good parallel.
And now we're even pushing for greater precision within infections,
Yeah.
realizing that individuals respond differently based on their unique endophenotypes, like their specific inflammatory and immune responses to the bug. Things like immune modulation for conditions like immune exhaustion and chronic infections. That's a new personalized frontier opening up. Let's delve maybe a bit deeper into how these molecular pieces actually fit together to determine phenotype. Specifically, Harrison's talks about how gene expression is tissue-specific. This seems really crucial for understanding why a drug might work beautifully in a lamb dish in a cell culture, but then fails spectacularly in the human body.
Yes, this is where we need to think about the concept of the protein-protein interactome. It sounds complex, but think of it as a comprehensive network map. A map showing all the known protein interactions within a cell or within a specific organ.
Okay, a biological circuit diagram.
Kind of, yeah. If we look at the entire human protein interactome, all possible connections, we can then identify a specific disease module. That's the subset of genes and proteins that are known or predicted to govern a specific disease process.
So if we know the disease module, theoretically, we should know how the disease works everywhere in the body.
Not quite. We know the potential pathways involved globally, but then we have to ascertain the actual gene expression within that module, specifically looking at its tissue specificity. Harrison's has a conceptual visual that demonstrates this really well.
Describe it for us.
Imagine the total number of genes in a particular disease module. Let's say it's 100 genes involved overall. When we filter that module for only the genes that are actually expressed, turned on in a specific organ, say the heart, the number of active genes in the module drops significantly. Maybe only 60 are active in the heart. Compare that to the spleen, maybe only 40 are active there. Or the brain, maybe 70.
Why is that reduction in the active module in each tissue so important?
Because it reflects the specific pathway or pathways within that larger module that is expressed in its functional entirety in that specific tissue. A gene might be present in your genome, sure, but if it's not actually turned on, not expressed in the heart muscle, or if its necessary protein binding partners aren't also co-expressed in the heart, then the entire pathological pathway that relies on that gene simply won't be active there.
So the drug targeting that pathway won't work in the heart, even if it works elsewhere.
Exactly. The clinician needs to know which specific functional pathway in the target organ is actually active, not just which genes are present in the patient's global genome. This individualized network context, considering tissue expression, brings us to what Harrison's describes as the ultimate goal of diagnosis in this new era. The reticulotype.
The reticulotype. Okay, sounds fancy. Named after reticulum, the Latin for network, I assume. Sounds like it could be the personalized GPS system for navigating a patient's specific disease.
That's a great way to put it. It really is the ultimate goal of individualized precision diagnostics. It aims to depict a patient-specific genotype-phenotype relationship, but visualized through a multi-omic network structure.
Multi-omics.
Meaning integrating multiple layers of data. Imagine taking all of a patient's unique molecular perturbations, their specific genetic variants from their DNA sequence, their differentially expressed genes from RNA analysis, their unique protein levels from proteomics, their metabolite profiles from metabolomics, and examining them all together within the context of their unique integrated biological network map for the relevant tissues. It's a dynamic, multi-layered picture.
So this reticulotype, this unique multi-layered network map for this patient, that then serves as the basis for designing truly individualized precision therapies. It's the highest fidelity picture we can possibly achieve of that person's disease at a given moment.
That's the ambition, that's the ideal. And this kind of network mapping also allows for smarter drug discovery and perhaps even more excitingly in the short term, drug repurposing. Finding new uses for existing, already approved, safe drugs.
Ah, okay. Harrison's has a visual illustrating this too, right?
Yeah.
Network-based drug repurposing using something called the proximity hypothesis.
Yes. It's a really clever application of network thinking.
So how does the proximity hypothesis work in practice? Lay it out for us.
It's essentially molecular connect the dots on that interactome map. Once we identify the specific disease module, that network of proteins causing the pathology we want to fix, we then look at the vast protein interaction network database to see how close the known targets of existing drugs are to that disease module.
Close in terms of network connection.
Exactly. Close on the map. If a known drug target is nearby the disease module, meaning the drug acts on a protein that directly interacts with or is only 1 or 2 steps away from proteins in the disease module, then it's considered a strong candidate for repurposing.
Why?
Because it's likely to have some influence, some therapeutic relevance on the function of that disease model. It's hitting the right neighborhood, so to speak.
Can you walk us through the real-world example provided in the text? I think it was multicentric Castleman's disease.
Certainly. Multicentric Castleman's is a rare, serious inflammatory disorder. Its exact cause was unclear, and it was previously treated with pretty nonspecific, often high-toxicity agents like chemotherapy.
Okay.
Network analysis of tissues from these patients revealed that a particular signaling pathway, the PI3 ACTA-mTOR pathway, which is involved in cell growth and survival, was highly activated. It lit up on the network map.
Right.
This evidence, derived purely from network proximity analysis, led researchers to look for existing drugs known to target that specific pathway, and they found one. Sirolimus, also known as rapamycin.
Which was already approved for other things.
Yes, already FDA approved, mainly for preventing organ transplant rejection, so its safety profile was well known. Because sirolimus targets the mTOR part of that pathway, clinical trials were initiated based on this network evidence. And indeed, sirolimus showed significant benefit for many Castleman's patients.
So that's rational drug repurposing, driven entirely by network intelligence, not random screening. And it potentially saves years and billions in developing a brand new drug from scratch.
Exactly. Huge potential there. And beyond finding entirely new pathways or repurposing drugs, precision medicine also helps optimize the use of existing drugs by assessing individualized pharmacogenomics, how a person's genes affect their drug response.
Absolutely. This is probably the most practical, widely implemented application of precision medicine today, isn't it?
It certainly is gaining traction. Think about established examples like genetic variants in the TPMT gene.
Right, that affects the Opurin drugs.
Exactly. Variants in TPMT severely affect a patient's ability to metabolize common immunosuppressive drugs like azathioprine or 6-mercaptopurine. If you give a standard dose to someone with low TPMT activity, they can suffer severe, life-threatening bone marrow toxicity.
But if you know their genotype beforehand.
You can dramatically reduce the dose or choose a different drug altogether, avoiding that toxicity. It's a classic pharmacogenomic success story. Or another common one, variants in the CYP2C19 enzyme.
That's involved in activating clopidogrel, the antiplatelet drug.
Correct. Some people are poor metabolizers due to their CYP2C19 genotype. They don't activate clopidogrel effectively after a heart attack or stent, leaving them at higher risk of clotting. Knowing their genotype allows the clinician to choose a different antiplatelet agent that doesn't rely on that specific activation pathway.
So these are established cases where genomic profiling lets us precisely tailor the use of a drug, maybe changing the dose to avoid toxicity or choosing an alternative agent entirely, thereby avoiding serious complications that a one-size-fits-all population-based dosing approach would definitely miss in some individuals.
That's the power of pharmacogenomics in action.
So bringing this all back to that crucial question, how precise do we actually need to be? The complexity is frankly overwhelming if you think about it all at once. But the guiding star, the principle we keep coming back to, is actionability.
Exactly. This ideal data set we're striving for, the reticulotype. It needs to eliminate the redundant information inherent in those overdetermined biological systems. It needs to help us weight the key determinants of a specific outcome, and then use that weighted data to create highly predictive signatures, whether they're phenomic signatures based on clinical features or genomic signatures, or ideally a combination.
The signatures that predict outcome or treatment response.
Right. And this naturally leads us to think about how clinical trials themselves are evolving, how they must evolve to support this personalized precision medicine idea.
Okay, this is the final area we need to discuss based on Harrison's. It relates directly to clinical trial design. How must it change to properly inform precision medicine? We need to distinguish clearly between the older strategies and the newer ones needed now.
Yes. Harrison's includes a visual depicting this evolution of trial design, which is really crucial. Traditional strategies often focus on one of two things, either reducing heterogeneity, trying to make sure the patient cohort enrolled was very similar clinically, or using what's called prognostic enrichment.
Prognostic enrichment. When we talk about that, What does it practically mean for the patient population being enrolled in the trial?
Prognostic enrichment means you deliberately enroll individuals who are already known to be at a high risk of the negative outcome you're trying to prevent, like death or disease progression.
So you pick the sickest patients.
Essentially, yes. For example, enrolling only patients with severe late-stage disease, or those who have biomarkers known to predict a very poor outcome anyway. Now, while this facilitates the trial, you need fewer patients to see an effect, potentially, and it enhances the overall apparent effect size of the drug because the drug has a higher chance of showing some benefit compared to a very high risk of failure in the placebo group.
Huh.
It doesn't necessarily improve precision in defining who specifically within that high-risk group will actually respond best to the treatment. It just tells you the drug might help very sick people more than doing nothing. It doesn't refine the target population much.
Okay. But the new paradigm, the one driven by all this multi-omic analysis and network thinking we've been discussing, is predictive enrichment.
Yes. Predictive enrichment is the strategy that flows directly from precision data. It uses detailed phenotypic and genomic features often clustered together using machine learning, maybe based on reticulotype analysis, to predict who among the broader patient population is most likely to have a pronounced positive response to the specific treatment under study.
Can you provide a really stark example to illustrate the difference between prognostic and predictive enrichment?
Certainly. Let's say you are studying a new cancer drug for lung cancer.
Okay.
Prognostic enrichment might enroll all patients with metastatic stage 4E lung cancer because they all have a high risk of death, a poor prognosis.
Right, that's the high-risk group.
Predictive enrichment, however, would go a step further. It might enroll only those patients with metastatic lung cancer who also possess a specific EGFR gene mutation, because preclinical data strongly predicts that only patients with that specific mutation will respond well to this particular drug.
Ah, okay. So the trial population using predictive enrichment is probably much smaller.
Much smaller, potentially, but the therapeutic signal, the chance of seeing a strong positive effect of the drug in that selected group is vastly higher because you've enriched for the patients who are biologically predicted to benefit.
This confirms our earlier point then. We don't necessarily need every single molecular detail about a person, but we do need those clustered signatures, those predictor biomarkers that define a reasonably sized cohort who are predicted to respond in a particular way to a particular intervention. That is the essence of finding those actionable high-yield targets within the incredibly complex biological network.
Absolutely. The boundaries to the actual practice of precision medicine, strictly speaking, they remain imprecise, right? Because we don't yet have every piece of data integrated perfectly. But they are becoming sufficiently predictive to be practical. Practical from the perspective of improving clinical care now, and certainly practical for designing much smarter, more efficient clinical trials. We are seeking those clusters of patients who share a functional disease module, a common actionable pathway, even if their ultimate clinical presentation or their lifetime environmental exposures might be slightly different. That is the threshold of actionable precision we're aiming for.
Okay, so let's try to synthesize all of this. What does this all mean for you, the learner, the clinician, the researcher, and really for the entire practice of medicine moving forward? Let's recap the key takeaways from this deep dive into Harrison's foundational argument for precision medicine.
Okay. First, I think we established that evidence-based medicine, EBM, while absolutely foundational and important, it suffers from providing treatment plans based on that mythical average patient.
Yeah.
And this reliance on population averages leads to those disappointingly high non-response rates, maybe up to 60% by some estimates in the real world of individualized clinical practice. And that creates significant economic and ethical dilemmas.
Second, we traced the history of diagnostics, from Morgagni and his autopsies onward. We saw how that historical system, based on late-stage pathology, often oversimplified disease complexity. It ended up grouping entirely different molecular etiologies, things like genetic disorders, infections, structural problems, under a single common late-stage end-organ pathophenotype, like end-stage kidney failure or heart failure.
Third, we detail the limitations of pure molecular reductionism, that mid-20th century dream of finding a single, simple cause for every disease. It failed for complex conditions because it largely ignored the crucial role of genomic context. Remember, the modifier genes, the epigenetics, the unique lifetime environmental exposures, all of which dictate the highly varied outcomes you see, even with the same primary molecular driver, like that single mutation in sickle cell disease leading to vastly divergent symptoms.
Fourth, Clinicians absolutely must recognize that biological complexity dictates two really confounding patterns in clinical practice. There's convergent phenotypes, where many radically different underlying diseases end up looking clinically the same, making diagnosis tricky. And there's divergent phenotypes, where the very same disease manifests in radically different ways across different individuals, making prediction difficult. Precision medicine has to be built on understanding that these are the norm, not rare exceptions.
Fifth, and this is really key for practicality, we determined that effective precision medicine does not require knowing every single molecular detail about a person, which is currently impossible anyway. Instead, success lies in identifying and targeting actionable primary drivers within the context of those overdetermined or redundant biological networks. This redundancy is what allows for effective clinical prediction and even drug repurposing through network analysis, like using that proximity hypothesis.
And sixth, finally, we recognize that the future of clinical research itself demands a fundamental shift in trial design, moving away from just prognostic enrichment, enrolling patients who are simply high risk overall, towards predictive enrichment. That means enrolling patients based on specific molecular or phenomic signatures that strongly predict a high probability of therapeutic response to that specific drug. It's about ensuring we match the right drug to the right patient cohort right from the start every time.
Taken together, this represents a monumental shift in thinking and practice. Harrison's really lays out how precision medicine demands this incredibly detailed, individualized characterization, the deep phenotyping, the endophenotyping, the genomic profiling, integrating social determinants, all feeding into creating that patient-specific reticulotype map.
And that detailed picture leads directly to our final provocative thought for you to consider. Given the vast, almost baffling complexity of human biology that we've just explored, maybe, just maybe, the greatest barrier to curing many common diseases right now isn't finding brand new, never-before-seen drugs. Maybe the bigger challenge, the lower-hanging fruit, is actually correctly identifying the specific patient group for whom the drugs we already have actually work perfectly or near perfectly.
Think about that 60% non-response rate again.
Exactly. If we can just target those existing successful therapies with true molecular fidelity to the subgroup that truly benefits, the therapeutic success rate in that group could skyrocket. The question then becomes a massive systemic one, doesn't it?
It really does.
How can our health systems possibly manage the cost, the complexity, the sheer data processing requirements of applying this level of deep, multi-omic phenotyping routinely for potentially every single patient globally? How do we actually make the transition from generalized care to truly individualized care on a planetary scale? That perhaps is the logistical and economic mountain we have yet to fully climb.